Well, I think the design of these studies, broadly speaking, has really been informed by the prior radiopharmaceutical therapy studies. So there was kind of an early template, which was kind of the pioneering work from the earlier studiers like Alsimka and Netter1 and Vision. And really, the study designs are quite similar. I think the challenge that they're facing a little bit in their design is the ability to allow for crossover from the control arm into the therapeutic arm. There's certainly some debate over, the the need to do this, the ethics of including this, and how it influences the data. But I think broadly speaking, the trial designs are quite similar to what's been done previously. Think they're going to have to because a lot of them, especially in the prostate cancer space, these have been, if you're studying primarily metastatic castration-resistant prostate cancer patients, post chemotherapy, these are patients that don't have a very long life expectancy. So you're not going to see as much of like the delayed toxicities that might be coming out. But now, if you're starting to move into, hormone-sensitive prostate cancer, oligometastatic disease, these other toxicities that are slow and kind of emerge long ways out. And the most notable ones in my mind here are, first of all, renal toxicity will become more of an important factor. And then secondly, we'll see what happens with it, but the development of secondary malignancies is also a potential feature that's been seen with other radioligand therapy. So those will become more significant in the long run. There's a lot of excitement around these. A lot of phase twos ongoing in this space. So we had, some notable ones were the ENZA-P study in Australia, led by Louise Emmett, which showed, a very strong augmentation of therapeutic effect by adding enzalutamide together with lutetium PSMA. An interesting feature of PSMA is that, at least in the short term, it appears to be the surface antigen appears to be significantly upregulated by treatment with androgen deprivation therapy. So the kind of hypothesis there is you start your androgen deprivation therapy, more PSMA, and then you hit it with a big load of lutetium PSMA. So you have a lot of radiation going into the treatment, into the cancer, and that's being actually studied in some sense in this STAMPEDE trial, because the STAMPEDE study, which is that multi-center trial in the UK, which I went through briefly, where they're starting ADT and then they give a higher dose of lutetium PSMA. They actually give 2 doses of PSMA 617 within 1 week. So they kind of have an accelerated dosing scheme. So I think that is a compelling combination that's going to probably play out in the long run. Other exciting combinations is lutetium PSMA plus immunotherapy. We have a study at my institution looking at this, where we're combining lutetium PSMA 617 plus pembrolizumab, and the leaders of that study are doctors Rahul Agarwal and Tom Hope. And this is also being evaluated in other centers as well. I think there is some evidence that the radiation from the lutetium PSMA kind of primes the immune system a little bit to become a little more active. And then other ones that are being investigated, for example, are PARP inhibitors, and which are encouraging further DNA damage, chemotherapy, and other things like that. So a lot of promise for combination therapies.